Good morning, everyone. Thanks to Asia Vasanya Congress of Nuclear Medicine and Biology for providing me an opportunity to speak on recent advances in management of radioiodine refractory thyroid cancers. Coming to the definition of radioiodine refractory thyroid cancers, I think the metastatic lesions which doesn't concentrate radioactive iodine in a whole body radioiodine scan or a post-therapy whole body radioiodine scan. Despite previous evidence of radioactive iodine concentration, the lesions lose the ability to be radioactive iodine avid later on, or the radioactive iodine concentration present in some lesions, not in others in the same patients, or metastasis progress within 1 year after radioactive iodine therapy. There are some special conditions which are also can be considered radioiodine refractory, like after receiving radioactive iodine dose of more than 600 millicurie based on the benefits and risks or short TG doubling time do not have good prognosis and may also be considered as a radioactive iodine refractory. Prior to saying that radioiodine whole body scan is a negative, I think we almost think about the iodine contaminations and the timing of whole body radioiodine scan. If there is a contrast CT or iodine containing food, I think we have exercised this and it has been published also regarding, of course, we require the CCT before 4 weeks, and those patients who have undergone the CCT before 4 weeks, and later on we have did the whole body radioiodine scan after 4 weeks, and we have 4 groups, and we realized that after 4 to 6 weeks were compared among the groups, and the mean, median, basal urinary iodine concentrations decreases drastically, and these patients can be done with whole body radioiodine scan after 4 to 6 weeks rather than 3 months, which the standard textbook writes. The CECT using non-lipophilic contrast does not result in long-term iodine retention, so that you can do the whole body radioiodine scan. Then only one can say that it is radioiodine negative. If you have a facility for measuring the radioiodine concentration, the urinary iodine concentration, then it is always better, so that you check that they are truly whole body radioiodine negative, and you can say them that. The next, the diagnosis of radioiodine refractory cancer is if the stimulated serum TG level is more than 10 nanogram per milliliter without having any raise in the anti-thyroglobulin antibody, or there is a rising titer of serum thyroglobulin, and the negative rate whole body scan, diagnostic scan usually have a lower sensitivity than the therapeutic scans because of the increasing dose. And one can do following the whole body radioiodine negative, a simple ultrasound neck, but if the TG is more than 10 nanogram, the FDG PET CT can be done. Simultaneously, also the somatostatin receptor scintigraphy and choline imaging can also be combined with the findings of FDG-CT, which can improve the sensitivity which has been suggested. Coming to the pathogenesis, abnormal function of sodium iodide importer, reduced NIS expression, BRAF mutations decrease the ability to take up radioiodine, and activation of the P13K pathway could also reduce the NIS expression at the transcriptional level. And if there is a BRAF induced repression of the sodium iodide importer, these have also been suggested in the pathogenesis of thyroid radioiodine refractory thyroid cancer. This is a picture showing a whole body radioiodine scan which doesn't concentrate any lesion, and the same patients underwent the FDG PET CT, which I will show you little later. And the FDG PET CT is a method of choice in mostly the DTC patient with a negative iodine whole body scan and detectable thyroglobulin, and sensitivity is around 70 to 90% in detecting metastasis. And this becomes an independent prognostic indicator also. And the FDG-avid lesions are seldom destroyed by radioiodine therapy alone, and identification of multiple FDG-avid distant metastases may spare the patient from aggressive local curative maneuvers. This is a picture of a FDG PET CT of the same patient which was showing radioiodine negative and the lymph node and lung metastasis, and this is showing. And this patient lived with this lymph node and lung metastasis for almost 2 decades following the FDG PET CT, and this might be, and the some group of patients which are not BRAF mutant or TOT promoter, they can lead their life very well. So it is wise to segregate them with the genetic test. FDG PET CT in persistent disease, you can see in earlier days the central compartment lymph node dissection was not in the vogue. By that time, this was persistent disease showing the central compartment lymph node only in this patient, and the patient is living beyond almost 2 decades now with a rising titer of serum thyroglobulin, and he tried to undergo another surgery which could fail, could not be possible. Coming to the FDG PET CT as a prognostic indicator, the serum thyroglobulin level is a young patient and it was around 300 nanogram, but we didn't find any lesion in these patients with the neither the long lesion in CT scan demonstrate any nodules in these patients. Coming to the management of little tennis with FDG PET, I think we did a study, the utility of fluorodeoxyglucose, and we realized that these patients can be managed with a regional scan. The results, we did 137 patients, and the 36 patients had metabolically inactive long nodules, and 18 were the metabolically active nodule. And the serum thyroglobulin and female sex were the only predictors for a positive PET scan. But in most of the patients, almost 97% of the patient, the disease was limited to the neck and the thoracic region. Thus, we suggested that a limited scan can be done in most of the patients rather than a whole body scan. Coming to the surgical outcome of these patients through resections, which was done by our surgical colleague endocrine surgery group, and we realized that we did a study. A total of only 12.5% of recurrent DTC patients with 77 lesions and 56 lesions were explored, and the dissections performed and the recurrent explored and could achieve biochemical cure only 12.5%. All these are disease confined to the neck. Remaining patients continued to have a high serum TG level, though it fell substantially in majority of patients. False positive scans are frequent in regions with a high prevalence of inflammatory diseases in our country. Hence, FDG PET directed reoperation should be taken up judiciously with a minimum FNSE or a biopsy of a cervical lymph node or any lesion which is there. Coming to the understanding of sodium iodide symporter, which is basically decreased expressions in tennis, I think we also checked regarding the iodine deficient population, or it is sufficient or iodine deficient population. We thought that it might be less expressed, but the NIS expression was similar in iodine deficient and iodine sufficient studies, and there are few studies which is comparable, and NIS expression was not significantly correlated with any clinical pathological risk factors, including patient age, presence or absence of metastasis, extracellular invasion, and size of primary tumor. NIS expression could accurately predict radioactive iodine uptake by metastasis in only 60% of cases. That indirectly provides us evidence that 40% of the metastatic lesions may not have NIS expressions, and the tune can go up to from 20% to 40% as radioiodine refractory thyroid cancers. Coming to the biochemical incomplete response, can we predict the tennis from the pre-ablative serum thyroglobulin level when you start treating these patients with radioactive iodine? We also did a study and we experienced that the age, central compartment lymph node metastasis, bone involvement, and pre-ablative serum thyroglobulin level in the first time following total thyroidectomy, we realized that the pre-ablative serum TG level is the only predictor of the biochemically incomplete response among 349 patients, and the ROC curve demonstrates that if you have pre-ablative level like 7.55 nanogram per ml the TG, then we have a sensitivity of 95%. And as we go on increasing 41, this becomes sensitivity at 70%, but specificity goes up. As the pre-ablative TG increased, we observed that the incidence of biochemically incomplete response increased from 5% with less than 10 nanogram to 85%. with more than 100 nanogram per ml. This is also out of 207 patients with lymph node metastasis. We have 45% of the patients who developed the biochemical incomplete response. It has also been realized that while 76.8% of the patients with no lymph node metastasis are complete response, whereas a low preablative TG level, despite lymph node metastasis shown in the whole body radioiodine scan, was a good predictor of complete response that has been seen. Coming to the raised anti-thyroglobulin antibody level, which is most of the time interferes in 25 to 45% of these patients, I think the clinical outcome of these patients with differentiated thyroid cancer and raised anti-thyroglobulin levels, how good or bad it is. We have also done a study. If you look to these, these patients this is the waterfall plot, and the raised anti-thyroglobulin antibody decreases over time. So this is nothing to be panicky, excepting the interference with the TG level. And I think there are very few patients those who have a very high anti-thyroid antibody level, they have only recurrences if it is more than 1000 nanogram per deciliter, or those patients who are over the time, this might take literally sometimes years to decrease the anti-thyroglobulin antibody level. So the raised thyroglobulin antibody was associated with the good clinical outcome, and it is not associated with the increased mortality. This has been also realized. And the 11.8 patients had a rising thyroglobulin antibody level. That means the majority of the patients will only have a decreased anti-thyroglobulin antibody level. Coming to the management plan of tennis patients, I think if they have recurrent or metastatic disease and the radioactive iodine has been given, or surgery, or radioactive iodine plus surgery, or local treatment with external beam radiotherapy, or thermal ablation, or embolization, or these patients can undergo radioactive whole body radioiodine scan and FDG PET scan, and subsequently if the FDG PET scan and this as the active surveillance and further radioactive iodine treatment can be done, or those patients who are having negative, they can undergo this radioiodine whole body scan and FDG PET CT, and the FDG PET CT is a positive radioiodine FDG PET CT or both, and they can also have active surveillance and further radioactive iodine treatment. Whereas those who are negative radioiodine uptake and progressive disease after radioactive iodine treatment, they are considered as a radioiodine refractory differential thyroid cancers. And this has to be kept in because they are high risk. It has the suppression of TSS level has to be maintained. And one can consider systemic therapy initiation depending upon their symptoms or failure to alternative treatment or system therapy, or disease threatening vital structure, or with an acceptable performance status. These patients can undergo also the genetic test, and if there is no genetic alteration found and the tumor burden is less than 2 centimeter and the progression is less than 12 to 24 months or unknown, active surveillance can be done. And those patients who have more than tumor burden, more than 2 centimeter unknown progression, one can consider the MAP kinase inhibitor initiation, and the progression is less than 12 to 24 months, the MKI initiation or selective tyrosine kinase inhibitors can also be done. Coming to the management part, there should be careful monitoring with active TSS suppression therapy or directed therapy like surgery, radiotherapy, or thermal ablation also can be done. Systemic therapy with molecular targeted therapy can be considered, or emerging therapeutic modalities like redifferentiation therapy, immunotherapy with pembrolizumab, or vascular endothelial growth factor trap. All these therapy like immunotherapy, vascular endothelial therapy, and redifferentiation therapy, though they are emerging, they have been tried, but still the success yet to come, and they are done in also sometime in a combinatorial approach with this management. Coming to those patients who are asymptomatic and not progressive, I think they should be watchful waiting under TSS suppression and should be considered for indolent disease, unresectable metastatic thyroid cancer. Asymptomatic, stable, or low tumor burden, low likelihood of developing the rapidly progressive disease, no adverse impact from disease burden, careful follow-up every 3 to 6 months, assessment of potential symptoms, imaging studies, and serum tests are also done. Coming to the reef differentiation agents, I think these have already been tried with retinoic acid, mostly all trans retinoic acid and 13-cis retinoic acid, which act on the nuclear receptors of the follicular cells, and they have not been found to be successful, which I will come later. And the MEK and the ERK inhibitors, PPR gamma agonist like your the MEK and ERK inhibitors like selumetinib and PPR gamma agonist like rosiglutagen, and HDAC inhibitors, histone deacetylase like valproic acids. They have all been tried, but it has not been found successful. This is in the range of around 10% to 20% with retinoic acid, which I have already shown. Several studies did not find any clinical value of iodine 131 therapy after retinoic acid pretreatment in patients with RAIR DTC. Coming to the MAP kinase pathway inhibitors, like those who have BRAF or RAS mutations, they can be treated. But if the radioiodine is responsive, you can see in the whole body scan 2/3 of the patients. But permitting iodine therapeutic administration can only be possible with 1/3 with a good amount of concentrations, so they can be treated. So because the constitutive activation of MAP kinase pathway causes inhibition of a variety of thyroid genes, including NIS, leading to the investigation of selective MAP kinase blocking agent as sulatinib or as a redifferentiating agents. Coming to the newer molecules for targeted therapy, selective kinase inhibitors, NTRK inhibitors like larotrectinib, entrectinib, or selective rate inhibitors like selpercatinib and praslutinib, with the assumption that rate PTC rearrangements are present in 5 to 25% of PTC. And we also can utilize the BRAF inhibitors like BRAF P600 mutations with 37 to 50% of the PTC. And those who are having this, they are biologically aggressive, and there is a decreased radioiodine uptake. And the NCCN guidelines suggest the BRAF inhibitors like vemurafenib or dabrafenib or in combination for systemic therapy or clinical trials to these BRAF inhibitors. I think selumetinib as a MEK inhibitors on the RAS and BRAF inhibitors, it has been tried, and there is a partial response, 21 stable disease and 11 progressive diseases has been demonstrated in 2012. All these, the most common adverse events included RAS, fatigue, diarrhea, and peripheral edema. It has been demonstrated that BRAF mutants had a longer median PFS compared with patients with BRAF wild-type cancers. Coming to the directed local therapy, I think this depends upon the location, aerodigestive tract, lung or cervical lymph nodes or brain and bones, number of lesions, tumor burden, technical feasibility. And for the locoregional disease like lymph nodes and all, the surgery is the first choice. Central or lateral neck dissections, if limited involvement of vital structures. In the case of intractable distant metastasis, locoregional disease therapy does not display significant benefits. And with the exceptions of decreasing the risk of potential lethal bleeding, alleviating symptoms, and removing the aerodigestive tract abrasion. Coming to the pulmonary metastasis, one can do laser ablation, metastatectomy, the EBRT, the external beam radiotherapy, palliate intrathoracic symptoms of hydrothorax or hydropericardium, disease progression, the recurrence and new metastasis, usual after resection of metastatic lesions, because this is mostly spread through the vascular route. Coming to the bone metastasis, isolated progressive or symptomatic metastasis, complete resection should be taken into consideration to improve survival, especially in young patients with a slow progressive disease. And anti-receptive therapy also can be tried with biphosphonate or denosumab. In the presence of an impending cross compression fracture, especially vertebral compression fracture, RFA with a cement augmentation also can be done for improving the symptoms. There is a study from our group. I think this has been shown that if you do skeletal metastasis and surgical intervention, what happens to them? I think it has been demonstrated with 32 patients comparable to non-intervention group of 59 with a surgical resection of skeletal metastases from different sites. I think you can see this Kaplan-Meier survival curve where it has been demonstrated there is no different in survival outcome of these. Thus, it has been considered. However, considering reasonable long-term survival intervention should be considered for a desired palliation and preservation of body function and to facilitation of radioactive iodine therapy by volume reduction. Coming to another local therapy, ethanol ablation, fast minimally invasive technique for the non-surgical treatment of metastatic cervical lymph nodes. This reduces basically the lymph node volume, but there is a limitation, difficulty in inducing a necrotic area, multiple doses for complete ablation. And coming to the percutaneous laser ablation, deployed thermal energy in precise and better outcomes are expected if it is used in smaller lesions and may cause permanent peripheral tissue injuries. Coming to the systemic therapy, I think already I have enumerated this systemic therapy. The most common one on the VEGF, which acts in the inhibitors receptors, is the sorafenib, lenvatinib, and cabozantinib, and vandetanib and pazotenib. Vandetanib the choice for. And the other drugs are also there on the different receptors, which has been depicted here in the mostly in the cell membrane, and the BRAF inhibitors like vemurafenib, dabrafenib, and salutinib and tramatinib. These are also in combination utilized as a redifferentiating agent, which has been tried and it is yet to be successful. Coming to the systemic therapy, I have already enumerated the targeted chemotherapy. Thyroid cancers are very vascular. That's why 3 VEGFR inhibitors are FDA approved already. The sorafenib, lenvatinib, and cabozantinib, which is utilized as the cheadle drug. And coming to the vascular endothelial growth factor trap, the anti-tumor effect of the MAP kinase inhibitors are attributed, at least in part, to their ability to inhibit angiogenesis in these vascular tumors. VEGF trap is a recombinant produced fusion protein consisting solely of human sequences of VEGFR1 and VEGFR2 extracellular domains and human immunoglobulin. There are phase 2 study, 40 patients were included in study of the vascular endothelial growth factor trap. I think with 4 milligram per kg IV was administered fortnightly, and the 34 patients had stable disease and 6 patients had progression and no patient had complete response. So thus there were no responses seen with a single agent, the vascular endothelial growth factor trap to date. In general, if you consider the tyrosine kinase inhibitors, they have also a lot of side effects and toxicity with mostly hand-foot syndrome, then their rashes, and they develop that's why we sometimes do drug holiday, sometimes decrease the dose, increase the dose. These are very common to the tyrosine kinase inhibitors like sorafenib, lenvatinib, and cabozantinib, and that's why one has to really see that whether the patient is symptomatic, what is the exact indications of these patients to this. Coming to the lutetium-177 dotated therapy, because the thyroid cancer patients who are radioiodine refractory DTC or thyroid cancer, they express basically the somatostatin receptors in around 40 to 65% of the patients in various literature. With gallium-68 dotanox scan or dotated scan was used to select such patients for PRRT as well as treatment response and toxicity. And the partial response and stable disease was seen approximately 60% of the treated patients with a duration of response in some literature with 3.5 to 11.5 months. In metastatic radioiodine refractory patients, PRRT may be considered as a therapeutic option with minimal toxicity, depending on SSTR expression in these cases, with a fraction of patients showing promising response. However, unlike JEPNET, there is less percentage and obvious objective response to PRRT in thyroid cancer patient. So this therapy has not been employed widely. But I think if you do both, and if the SSTR expression is quite high in comparison to AFDG PET, then I think these patients can be considered as another option for treatment of metastatic thyroid cancer, which are radioiodine refractory. Coming to the conclusion, options for treatment of patients with advanced radioiodine refractory differentiated thyroid carcinoma is suboptimal till date. However, it is increasingly evolving and fine-tuned in spite of the availability of the tyrosine kinase inhibitors, which is still to be toxic, costly, and a lot of side effects, and they have also a resistance phenomena, which is well described. While the introduction of new therapies for multiple molecular targets has made it possible to extend little progression-free survival, their impact on overall survival is still unclear. Choosing molecular targeted therapy with appropriate indication is extremely important. Otherwise, it can cause more harm rather than benefit to metastatic thyroid cancer patients. Thank you for patient listening. If you have any questions, you can ask me.